everybody. So here's my presentation. I'm doing it on fibromyalgia. So as an introduction, fibromyalgia is a chronic and widespread pain disorder. It affects 2 to 5% of US adults and 0.5 to 5% of other Western populations. There has been growing recognition of fibromyalgia by both patients and healthcare professionals, making it a commonly seen disorder in primary care, although it is still under-recognized. This has also led to an economic burden on healthcare resources. Finally, as we move through the presentation, you will note that the management of these patients can be challenging, and it is therefore an important topic to cover as future healthcare providers. So here are the objectives for the presentation. So pathophysiology, as I'm sure many of you know, the pathophysiology of fibromyalgia is uncertain. And the etiology is unknown, but it was discovered in England in the mid-19th century. It is a controversial condition as many patients look well but have no obvious abnormalities on physical exam, labs, and radiographic studies. Because of this, organic illness role in the condition has been questioned, and some consider it to be a condition of psychogenic or psychosomatic in nature. With that said, there is some ongoing research that suggests it may be a disorder of the pain regulation that is often classified as a form of central sensitization, which also explains the changes in sleep, mood, and energy. And we'll talk about that a little more in a bit. So for common presentation, fibromyalgia is characterized by its widespread musculoskeletal pain and is 6 times more likely to be found in women between the ages of 20 and 55 years. Other common symptoms include fatigue and sleep disturbances, as well as cognitive and psychiatric disturbances or symptoms. So widespread musculoskeletal pain typically involves at least 6 sites, although sometimes the pain may be initially localized. You will often hear things like, I feel like I hurt all over, or it feels like I always have the flu. Pain is usually in the muscles, although it may at some points involve the joints, and there may not be any swelling noted on the exam. So you can see that. So fatigue is usually moderate to severe persistent, and minor activities seemingly aggravate the pain and fatigue. Prolonged inactivity can also worsen the symptoms, and patients are often stiff in the morning and feel unrefreshed, even with the needed sleep amounts. The morning stiffness can be difficult to differentiate between rheumatic diseases. Finally, these patients often report sleeping lightly with frequent waking and difficulty falling back asleep. The fibrofog is often the cognitive disturbance that is experienced with fibromyalgia patients and involves problems with attention and difficulty performing tasks that require rapid thought changes. Additionally, depression and anxiety are found in about 30 to 50% of patients at the time of their diagnosis. Overall, there are more psychiatric disorders, including bipolar and PTSD, etc., found in fibromyalgia populations than in the general population. Another common symptom in fibromyalgia patients are headaches, present in over 50% of fibromyalgia patients and include tension and migraine headaches. Paresthesias may also be present in the arms and legs, and electrophysiologic testing is usually unremarkable. Multiple somatic symptoms are also frequently present and can include chest wall and abdominal pain, IBS symptoms, bladder symptoms, GERD, dry eye, and orthostatic hypotension, and more. And then I just have kind of a picture of some of the systematic symptoms that may be present, as well as other symptoms, including the CNS, joints, muscle, chest. You can see the picture and go through that. So overall, when exploring the presentation and symptoms of these patients, we must remember that the symptoms must be present for at least 3 months and not explained by any other condition in order to be eligible for a diagnosis of fibromyalgia. So here are some of the differentials to keep in mind as we approach the patient with the symptoms that may resemble fibromyalgia or when we are considering a fibromyalgia diagnosis. With each of these differentials, I have important differentiating factors noted next to them. So as you can see, rheumatoid arthritis and lupus might be a considered differential, but with those, you're going to have symmetrical polyarthritis, system dermatitis and nephritis. There's going to be an increased ESR, which we're going to talk about in a little bit, and serologic abnormalities. As you move forward, say hypothyroidism, you're going to have abnormal thyroid function tests, which you're not necessarily going to have with fibromyalgia patients, which you aren't going to have. All right. So for the history, as we proceed with the history of these patients, it's important to remember that the demographic of fibromyalgia is usually 6 times more often in women ages 20 to 55 years, but it can be seen in anyone. We discussed the common presentation on previous slides, so keep in mind those symptoms and chief complaints. Additionally, there may be limitless amounts of concurrent medical conditions present, but we must differentiate these symptoms from the diagnosis of fibromyalgia. And as mentioned previously, the symptoms must be present for at least 3 months with no other explanation. Cultural and social considerations may affect the severity of the patient's pain by the time they seek help. For instance, some cultures do their best to hide pain, and it may not be only perceived as less painful to them, but it might also be extreme by the time that they seek care. Or in many social situations, fibromyalgia is a stigmatized condition, and it may deter patients from seeking care. These are important considerations when obtaining a history from these patients. As mentioned previously, fibromyalgia has created economic burden on the healthcare system due to its widespread symptoms and difficulty in diagnosing. While we must think of the entire healthcare system, these patients have also experienced multiple healthcare visits and diagnostic tests, which can create personal economic burden. This is an important factor when we are evaluating the approach to their care. Finally, when we evaluate ethical considerations, we are faced with the common ethical concern of the treatment of pain. As fibromyalgia is often perceived negatively, we face the ethical dilemma of treating their pain when we cannot provide an objective evidence, which we'll discuss in a little bit. This is often a problem these patients may have faced in the past, stating that no one believes me. As providers, we face the concern of our pain relief prescriptions being monitored, belief in the patient's pain, and drug seekers when addressing the ethical concerns of treating fibromyalgia patients. So when the interview is started, old carts will likely be explored first. The onset is usually insidious, location is widespread, and the pain is pretty constant. Most tried treatment options are not helpful, which is why they are seeking help from a primary care provider. In exploring past medical history, it is again important to discuss current comorbidities, past surgeries, and past illnesses and injuries, as fibromyalgia diagnosis cannot be related to other conditions with known causes. Similarly, the family history, exploring potential causes in the family history like rheumatoid arthritis or musculoskeletal disorders, or even psychiatric disorders may be beneficial in providing information for an area to explore in these patients. Social history questions should be similar to the typically asked questions about substance abuse, as these are often risk factors for many disorders, but also in exploring what they do for work and hobbies. This is important because the pain may be related to positioning or injury at work. For instance, someone who is always at a computer desk may have pain related to sitting at the desk, or carpal tunnel syndrome because of typing all day. Overall, as we discussed later in the presentation, when diagnosing fibromyalgia, we must rule out other conditions, and the interview and history portion can provide a great deal of information into areas that need to be explored in the diagnosis of this patient. Pertinent positives are the core symptoms of widespread pain, fatigue, and overall disturbances in their life, while pertinent negatives would include many diagnostic tests being negative, and the physical exam will reveal no swelling or arrhythmia. We will discuss the red flags later in the presentation. On the physical exam, tenderness will be noted with modest palpitation in multiple soft tissue sites. These sites can be seen with the image that I have provided. An important factor to note and pertinent negative is that there will be no swelling or arrhythmia of the joints or soft tissue when examining these areas. Additionally, a neuro exam will sometimes reveal minor sensory and motor abnormalities, again noting that there are no other conditions that could have caused it. Patients with fibromyalgia are generally diagnosed clinically based upon a thorough medical history with particular attention to pain characteristics, sleep, fatigue, and other associated symptoms and differential diagnoses. Thorough physical exams should be performed with attention to joint and neurologic examinations. Palpating tender point locations is no longer recommended, which you saw those tender point on the last slide. But it's no longer recommended, but knowing the locations may be helpful in diagnosing fibromyalgia. There are no confirmatory tests or biomarkers, and testing should be kept minimal. So a CBC and ESR/CRP are often done to remain cost-effective. If there is a concern for a potential associated disease, tests for that should be done, such as a TSH if you're suspecting thyroid disease. CBC, ESR, and CRP, though, will all remain normal when you get those test results back. And you can kind of see this is from up to date. So the characteristics and diagnostic evaluation for fibromyalgia, you'll see the history, the physical exam findings, and the laboratory findings. for fibromyalgia. When approaching the patient with the symptoms and physical exam findings we have discussed, the first step is to rule out any causative differentials and to keep testing to a minimum for cost-effective and timely diagnosis. The table on the left of the slide is a great resource for cost-effective diagnosis of fibromyalgia by Dr. Goldenberg on UpToDate. Here he discusses the common or characteristic symptoms, ruling out other conditions, the length of time symptoms have been present, and exclusion of systemic diseases. If these are present, the CBC, CRP, and ESR are normal, and there is no other explainable cause, a diagnosis of fibromyalgia can be made. So UpToDate noted that if you are hesitant in diagnosing fibromyalgia, that the 2010 ACR preliminary diagnostic criteria may be used, although it is important to note that there are some limitations. So here are the criteria for this. So you have to have a widespread pain index greater than 7 and symptom severity scale greater than 5. And they give another alternative to that. Symptoms must be present for at least 3 months. I think I've kind of drilled that into everybody's head. And no other disorder is explaining the symptoms. Again, something else I've kind of drilled in the head. So here you can see the image over here that has the regions for scoring of widespread pain index. So that widespread pain index, that has to be greater than 7. At least 7 of these spots need to be checked off. Additionally, the AAPT criteria from 2013 may be used. The core diagnostic criteria for this are 6 or more pain sites from 9 possible sites, which you can see on this side here, the 9 possible sites. So you need at least 6 of them. Moderate to severe sleep problems or fatigue, and both 1 or 2 must be present for at least 3 months. And again, here's that image that kind of helps you identify the body sites. Outside of the proposed diagnostic criteria mentioned on the 2 slides before, there's also a questionnaire called FibroDetect. It is 14 questions and focuses on the patient's pain and fatigue, personal history and attitudes, symptoms, and the impact on the patient's life. It has a predictive accuracy of 0.86 for fibromyalgia and non-fibromyalgia detection, and sensitivity of 90% with a specificity of 67%. And there's a cutoff score of 6. I was trying to get a example of this, but from what I can tell, this is something that would probably have to be purchased. So this is one of my literature reviews, and I decided to put it in here because it explores the diagnosis of fibromyalgia and the challenges associated with it. So in 2018, Badari et al. Conducted research on the challenges of fibromyalgia diagnosis, from meaning of symptoms to fibromyalgia labeling. They discussed that there is confusion and no clearly defined points that separate fibromyalgia from non-fibromyalgia. In addition to it, it also has become a contested illness. The conclusions drawn from the research was that precise fibromyalgia diagnosis may be elusive, and it seems that the meaning of fibromyalgia symptoms and the conceptualization of complaints in a logical manner needs to challenge practicing providers. That means that logic and complex diagnostic challenges cannot be paced into limited capacity of fibromyalgia criteria. The criteria is only current methods that can be used in classifying fibromyalgia patients are missing important pieces such as invalidation, psychosocial factors, and heterogeneous disease expression. Overall, the research has shown that fibromyalgia should be viewed as a whole and not a medical specialty, as labeling these patients as having fibromyalgia or not, and evaluating these patients requires meticulous and discretionary approaches. So before we move into the management of these patients, let's touch on some of the red flags. So according to the NHS Foundation Trust in 2018, red flags that indicate the need for further investigation include predominant articular pain, swelling, or stiffness, and/or a raise in CRP, as this indicates arthritis. Also, predominance of weakness rather than pain with a raised CRP, as this may indicate myositis. Raynaud's or photosensitivity, as this may indicate lupus. And axial stiffness, which may indicate spondyloarthritis. Additional red flags from other sources are also provided on this slide. Classic red flags that require specific and rather urgent evaluation would include weight loss and unexplained infections or fevers. profound fatigue and cognitive dysfunction are also concerning and exceed the expected symptoms associated with fibromyalgia. Other symptoms on the list may indicate other or more severe diseases or conditions and would be a red flag when exploring a fibromyalgia diagnosis. To quickly review, these might include lymphadenopathy, cardiac murmurs, rashes, significant muscle wasting and weakness, abnormal gait, focal neurological symptoms, abnormal reflexes, and synovitis or joint swelling. Assuming that no red flags are present in the patient and a fibromyalgia diagnosis is made, the most immediate action would be to address the patient's pain, any associated symptoms or comorbidities, such as sleep disorders or depression, promote exercise, and to start non-pharmacological and pharmacological treatments, and most importantly, to educate the patient on their disorder. If there are any red flags present or abnormal findings on the physical exam or labs, then the most immediate action would be to follow up on those abnormal findings or red flags. Overall, fibromyalgia is not an urgent or life-threatening disease, and it can be argued that the immediate actions are not truly immediate. With that said, the immediate actions are the first steps in the treating of fibromyalgia patients, and therefore I'm approaching the non-urgent actions as actions that will occur in future appointments. This includes considering referrals, especially for refractory cases, continue to adapt the goals and evaluate their responses to treatment, continue to educate not only to the patient, but also yourself on fibromyalgia, and to provide support groups and resources. So the management of these patients. So prior to managing fibromyalgia, we need to individualize the plan and find out if there is a prominence of particular symptoms, past medication experiences, the patient's cost and insurance, comorbidities, and the level of physical fitness or ability to exercise. The goal is going to be to reduce the major symptoms, but to keep treatment individualized, multidisciplinary, and to use non-pharmacologic and, if needed, pharmacologic therapy to exercise, address comorbidities, and most importantly, to educate the patient. The initial treatment should include patient education, which I will discuss in a few slides. Additionally, it is important to address the comorbidities that commonly affect fibromyalgia patients, such as sleep disturbances and psychiatric symptoms and disorders. This may include diagnosis and/or treatment for obstructive sleep apnea, restless leg syndrome, depression, etc. The patient should also begin an exercise program. This should be specific cardiovascular fitness programs that is individualized by preference and physical status of the patient. Low-impact aerobic activities are often successful, but should include 30 minutes of aerobic exercise at least 3 times a week. Most patients can start a low-dose tricyclic medication, such as amitriptyline, at nighttime, as they are effective, availability, and less costly than other options. If symptoms are experienced, then cyclobenzaprine may be used as an alternative. Some sources, such as Arnold et al. In 2012, suggest initial treatment should also include CBT. So in terms of pharmacological treatment, you want to start with a tricyclic antidepressant, such as amitriptyline. If the patient has inadequate response to treatment, the first step is to ensure that there is adequate adherence to the pharmacological and non-pharmacological treatments. Additionally, comorbidities should be reevaluated and their treatments as well. After these have been evaluated, pharmacological treatments can be reevaluated after an adequate trial of 1 to 3 months of a low-dose TCA. If there's no response, then a switch from a TCA to a SNRI or anticonvulsant, such as pregabalin, may be done. The choice depends on the patient's other presenting symptoms. For instance, if the patient is experiencing prominent fatigue and depression, then an SNRI might be more beneficial. Whereas if the patient has significant sleep disturbances, they might do better with pregabalin. Overall, it is important to note that there is little benefit from analgesics, such as acetaminophen, NSAIDs, and opioid analgesics. In fact, opioid use is actually associated with increased harm and should be avoided in fibromyalgia. Overall, acetaminophen and NSAIDs are often prescribed as adjuncts to therapy, and there is absolutely no evidence showing that this is beneficial to fibromyalgia patients. So here's a stepwise approach that pretty much sums up what we have talked about, and this is from Up to Date. So you have your initial approach, confirm your diagnosis, educate, so big, evaluate and treat the comorbidities of the disorder, which would be sleep or mood disturbances. Most patients in your initial approach will include like that amitriptyline that I talked about, or it might be that antidepressant or pregabalin, depending on the comorbidities that they're experiencing. And then exercise. Make sure this is individualized and something that they can do. If they're not responding, as we kind of talked about, consider referrals, combinations of drugs, physical therapy, just multidisciplinary, get people involved. So I found this algorithm to be very helpful in the management of fibromyalgia patients. As you can see in the algorithm, diagnosis and treatment is dynamic, but the core principles remain the same throughout. Other important tips I found throughout the algorithm was to know the community and team and resources that are available in treating fibromyalgia. Be sure to collaborate with the patient, treat comorbid conditions, and write non-pharmacological treatments as prescriptions, which I found that interesting, but it's a great tip, write exercise down on a prescription pad. Most importantly, be sure to continue to set goals and to educate. So yeah, you can look at this, you have confirm the diagnosis, educate, collaborate, and then be proactive and prepared. So know your patient, know your team, know your community. Use pharmacotherapy if needed for pain and the other symptoms like we talked about. Treat your comorbid conditions and non-pharmacological therapies. Write them as prescriptions. Sleep hygiene, physical activity, CBT. And then main focus on progress and the daily ups and downs. So this was a great algorithm. So here's another image. This one is from Cohen in 2017, and it summarizes not only approved treatments, but also complementary options, which I think are great because a lot of times patients are interested in that. So we have our patient with fibromyalgia. You have your patient education, which again is really, really big. You have your pain clinics, which we'll talk about in a little bit. Your pharmacological options. You've got analgesics, which again, there's been a lot of studies that show that there's actually no benefit to these. Your neuromodulatory agents, which go back to it being a central disorder versus a peripheral, and you can see your tricyclics, the SNRIs, and then it has some other options, your gabapentins, things like that. And then miscellaneous, they have cannabinoids on here. Then you have your non-pharmacologic options, which give you all these other options that we can use in non-pharmacologic approaches. You have your sleep hygiene, occupational therapy, hydrotherapy, psychological therapy, acupuncture, and so on. So another great figure to explore. So this is another one of my literature reviews, and I decided to put this in the treatment and management section because it has to do with the treatment of these patients. So when searching for research on treatment, I came across an overview of systematic reviews from 2020 that explored the efficacy and safety of duloxetine and amitriptyline in the treatment of fibromyalgia. This research was performed because these two medications are frequently used and there is no agreement about which drug is more effective or safer. Again, this research was done by a systematic review, and the results revealed the following. 1, that amitriptyline has low evidence for pain, moderate evidence of sleeping and fatigue, and high evidence for quality of life. Duloxetine, on the other hand, had high quality of mood disorders. Low evidence showed higher acceptability and increased safety in older patients. So overall, the conclusion of the study showed that both antidepressants were revealed to be effective in the treatment of fibromyalgia, but they differed according to the patient profile and symptoms. And this goes back to a lot of what we've already talked about really making sure that the treatment is individualized and you're addressing the comorbidities that these patients are experiencing and tailor the treatment towards those. All right, so patient education. It is important to keep in mind that many of these patients have felt rejected by medical professionals and may fear they have a life-threatening illness. They have been They have often been through multiple diagnostic evaluations, consulted with many specialists, and lived with fibromyalgia for years prior to a diagnosis. One of the most important elements of patient education includes reassuring the patients that this is a real illness and that it is benign in nature. They will not physically deteriorate, and it is not life-threatening or cosmetically concerning. There should be a discussion of the relationship between the mood disturbances, abnormal sleep, fatigue, and pain perception, especially if considering TCAs or anti-seizure medications. And again, and we'll talk about this some more, but it goes back to it being the pathophysiology being considered that it's a central disorder. So centralized pain should also be explained, and this is where we're going to explain that. So that the patient understands that chronic pain disorder comes from the CNS and why there is not an organ, structure, or peripheral pathology. This should be done via a biopsychological model and not a biomedical or illness model, to emphasize that it is not a physically deteriorating or life-threatening condition. This may be added with lab results noting the lack of persistent infections. As the biopsychological model is discussed, stress and mood disorder should also be mentioned, as chronic pain and depression share biological features and may precipitate or aggravate fibromyalgia, and the importance of stress reduction and relaxation techniques. Those with mood disorders should be strongly encouraged to treat their concurrent disorders. Patients should also be urged to correct poor sleep habits and to obtain treatment for sleep disorders and establish good sleep hygiene, as lack of sleep may contribute to pain and other symptoms of fibromyalgia. This may include treatment for obstructive sleep apnea or restless leg, avoiding stimulants such as the TV, cell phone, or caffeine before bedtime, sleep in a dark and quiet area, and avoid or manage factors that affect sleep quality. Exercise and weight loss are important for healthy living in general and help to reduce pain, although patients should be warned that some pain may be experienced when initiating exercise programs. It is important to discuss that sedentary lifestyles are a major risk factor for fibromyalgia. With chronic illness, patients often catastrophize impacts of their pain and outcome, and therefore our maladaptive chronic illness behaviors should be discussed and CBT should be recommended. Overall, patients should be advised that their prognosis of symptoms will wax and wane, and some pain and fatigue will generally persist. With that said, emphasis should be provided that most patients will live normal and active lives with treatment. As mentioned before, treatments should be given 1 to 3 months prior to adjusting or changing. Therefore, a follow-up should occur in about 1 to 3 months. With that said, if there are any side effects to treatments or if symptoms worsen, the patient should be seen sooner. Referrals may be needed to help manage fibromyalgia patients. A referral for physical therapy might be needed if a patient's pain is in the way of exercise or being active. Psychological referrals for CBT and pain management may also be required. Cognitive behavioral therapy referral criteria is rather simple with fibromyalgia, and in my area, pain management referral criteria for fibromyalgia patients just includes having a chronic pain disorder. Other options may include consultation rather than referral, although referral may be indicated. If there is a concern for rheumatological conditions or other comorbidities, a referral may be necessary or a consult at least explored. When consulting provider to provider, there is no real criteria, but in cases such as sleep specialists, there may be a need to provide sleep disorder or concerns such as sleep apnea symptoms. If a patient is unresponsive to treatment, a referral to rheumatology may be adequate. If there is assistance needed for prescribing combination treatments, confirming diagnosis, and reevaluating of treatments, or the overall assistance and management of comorbid musculoskeletal conditions. Overall, multidisciplinary treatment is often associated with the best outcomes, and the use of pain clinics is a favorable approach, and there are providers that are experts in the care of fibromyalgia in many pain clinics around the country. So here is my last literature review, and this is some current research that I found kind of interesting on fibromyalgia. So there is a lot of current research out on fibromyalgia. One that I found to be quite interesting is this one from 2020. It explores hearing loss and fibromyalgia compared to those without fibromyalgia. It also explored the relationship between drugs and the comorbidities and the development of hearing loss in fibromyalgia patients. The study concluded that fibromyalgia influences hearing loss, and the fibromyalgia mechanism is again related to the central nervous system, abnormality in sensory processing. The study ended with a recommendation that healthcare professionals should provide screening for the risk of hearing loss and hearing loss prevention counseling. So again, and I'm about to go into the conclusion, but again, interesting enough, fibromyalgia, the pain condition, is linked to the central nervous system, which is why you have the ties to sleep disorders and mood disorders, and why analgesics aren't very helpful. But also why it's not a deteriorating condition. So very interesting information on the pathophysiology and why certain treatments work, why TCAs work, and we really need to know that in order to treat these patients, because they're going to be like, why are you prescribing me an antidepressant? I have pain. So if you can really understand that and explain that to the patients, they'll understand it better. So in conclusion, fibromyalgia is a chronic widespread pain disorder with many associated symptoms such as fatigue, sleep disorders, and psychiatric disorders. The cause of fibromyalgia is ultimately unknown, although some sort of CNS disturbance is thought to play a part in the disorder. In order to make the diagnosis of fibromyalgia symptoms, again, this is a big one, the symptoms must be at least present for at least 3 months, and the physical exam is usually unremarkable except for widespread tenderness. There's also some clinical tools that may aid in the diagnosis, but they all have their faults. There's no diagnostic test that can confirm fibromyalgia, but a CBC, CRP, and ESR should be performed, although they will be normal in a fibromyalgia diagnosis. Finally, the treatment of fibromyalgia should include education, addressing comorbidities, exercise, and initially tricyclic antidepressants. Each treatment should be given at least a 1 to 3 month trial before changing it. Additionally, don't hesitate to refer or consult. And again, educate, educate, educate. So here are some important links, and all of these are actually links. So you have your National Institute of Arthritis and Musculoskeletal and Skin Diseases, the National Fibromyalgia Association, the National Fibromyalgia and Chronic Pain Association, National Fibromyalgia Partnership, American Fibromyalgia Syndrome Association, and of course, up to date, they had a lot of great algorithms and images and resources. And then these are the discussion questions, which I will get on the board, and my references. All right, thanks everybody.